Welcome to the PN2 Module 10 recorded lecture on metabolism. I can hardly believe we are at week 10 already. It has just flown by. And once again, we have our two slides related to the resources that are available to you and that you are held responsible for those, as well as the objectives for this unit. We'll start by talking about a client who presents with a request for weight management support. Think about what topics should be discussed with this individual. Topics should include what a healthy body mass index is, whether this individual is overweight or underweight. Also, we should discuss issues related to diet and exercise. To calculate your BMI, here are two formulas that you can use, one based on kilograms and your height in meters, as well as one based on weight and your height in inches. Or, since there are so many apps that are readily available, you can just go to an app and put it in and it will calculate that BMI for you. This is not a formula, neither formula is needed to be memorized, just making it available to you in case you want it. What is important to know is that the normal range for BMI. A BMI of less than 18.5 is considered underweight. Normal is 18.5 to 24.9. If you are above 25, but only up to 29, you would be classified as overweight. And if you are between 30 and 39, you're considered obese. Greater than 40 is considered morbidly obese. BMI is just one tool that we use to predict healthy body weight. Other predictors for coronary artery disease and diabetes include the waist circumference, or WC, and with this, the distribution of the excess body fat rather than the degree of obesity has been used to predict increased health risks. For example, with the waist circumference is a stronger predictor of coronary artery disease than the BMI. So a waist circumference greater than 35 inches in women and greater than 40 inches in men indicates central obesity. So that means obesity in the core of your body. And that is a major risk factor for coronary artery disease, stroke, type 2 diabetes, and some cancers such as colon and breast cancer, as well as sleep apnea and early death. The waist to hip ratio is also a predictor for coronary artery disease, and this measure differentiates peripheral lower body obesity with central obesity. So a WHR of 0.95 or greater in men and 0.8 or greater in women indicates android obesity with excess fat at the waist and the abdomen. So to calculate the WHR, you take the waist measurement and divide it by the hip measurement to get that number. So for those of us ladies who have curvier hips and a smaller waist, that's an advantage for us as far as these two tools that have proven to predict the risk factors for the conditions we just mentioned. Over the years, there have been just tons and tons of different types of diets, I use air quotes with that tell us what is the healthy way to eat. And, you know, we had low fat for a while, everybody was doing low fat, and then we went to the low carb. So we had the Atkins diet. Now the new rage is keto. For our test purposes, we are going to be referring to our textbook, and it guides us to the 2010 dietary guidelines for Americans to define what constitutes a healthy diet. And so to meet our nutritional needs according to this standard, 45 to 60% of calories should come from carbohydrates, and fat should be limited to 20 to 35% of daily calories. Protein intake should be limited to 10 to 35%, and there is no percentage of calories intake each day for specific vitamins. Most of our fat digestion takes place in the small intestines through the action of gastric lipase, pancreatic lipase, and bile. And according to the American Dietetic Association, all foods can fit into a healthy diet if the portion sizes are appropriate, the foods are consumed in moderation, and regular physical activity is included. You can go to the Choose My Plate if you want more information for yourself personally. So I'm going to make you reach back to your nutrition class and think about which vitamins are fat soluble. If you answered A, D, E, and K, you are correct. B and C are water-soluble vitamins. And why does this matter? What's important about that? And this is because when we do some of our fad diets, people, especially those who choose a very low-fat diet, they can have an increased risk of vitamin deficiency even if they're eating those vitamins, because if you don't have enough fats in your diet, and then you can't absorb those specific vitamins. It's recommended to get 30 minutes of exercise most days of the week to improve cardiac health, brain health, and metabolic health. You have a client who's diagnosed with Graves' disease. Consider how you would explain this disease process to the client. Graves' disease is an immune system disorder that results in the overproduction of thyroid hormones, causing hyperthyroidism. Although a number of disorders can result in hypothyroidism, Graves' disease is the most common cause of it. Because our thyroid hormones affect a number of different body systems, signs and symptoms associated with Graves' disease can be wide-ranging and significantly influence your overall well-being. While Graves' disease can affect anyone, we see it most often in women and usually before the age of 40. Our primary treatment goal is to inhibit the overproduction of the thyroid hormones and lessen the severity of the symptoms. Graves' disease is caused by a malfunction in the body's disease-fighting immune system, although the exact reason why this happens is still unknown. One normal immune system response is the production of antibodies designed to target a specific virus, bacterium, or other foreign substance. In Graves' disease, for reasons again that aren't well understood, the body produces an antibody to one part of the cells in the thyroid gland, which is a hormone-producing gland in the neck. So normally thyroid function is regulated by a hormone released by a tiny gland at the base of the brain, the pituitary gland. The antibody associated with Graves' disease, that antibody is called thyrotropin receptor antibody. You don't need to memorize that. Anyway, it acts like this antibody that's associated with Graves' disease mimics the thyrotropin receptor antibody, and it starts to regulate the pituitary hormone. And so it overrides that normal regulation, and then it causes this overproduction of the thyroid hormone, which leads, to hyperthyroidism. Signs and symptoms of Graves' disease or hypothyroidism include anxiety and irritability. Often we see this fine tremor in the hands or fingers. There's heat sensitivity and an increase in perspiration or warm, moist skin. Patients often experience weight loss despite eating normal amounts of food. When you palpate the thyroid gland in the neck, you can feel the enlargement. We call that a goiter. And women will see a change in menstrual cycles. Men can experience erectile dysfunction or decreased libido. Frequent bowel movements are common with this. One of the classic signs we actually see, it's usually the most obvious, are these bulging eyes. They call that Graves ophthalmopathy. Wow, that was a mouthful for me today. I'm tripping over my tongue. You might also notice thick red skin, usually on the shins or the top of the feet. We call that Graves dermopathy. And a rapid or irregular heartbeat or palpitations can also occur. We're also looking at labs You're going to see with Graves' disease and hypothyroidism, low TSH, but high T4. Diet medications for clients with hyperthyroidism will include, because they have an increased need for calories, carbohydrates, and proteins. Remember that the proteins are especially important because the patient or the client's at risk for a negative nitrogen balance. We're looking at using medications to treat any diarrhea, providing a fan for comfort, and use of an air conditioner in the summer, and then taking daily weight measurements to make sure that the patient doesn't continue to be losing weight. Medication therapy, the propylthiouracil or PTU, is a medication that can be prescribed for women who are pregnant or breastfeeding. It's safe for that if it's absolutely necessary. The radioactive iodine and the methimazole are not appropriate for pregnant women, but men and non-pregnant women may be prescribed that. They often do a thyroidectomy, and then when that happens, then they have to have thyroid replacement medications for life. So they initially are hyperthyroidism, they have that, and then after the surgery, they become hypothyroidism, and we have to replace the thyroid medication. Calcium may also be needed if the parathyroid organ is damaged during surgery. And then always remember we want to provide some pain medication after surgery. We're going to talk in the next slide about post-thyroidectomy care. The surgery is taking place in the throat, so that's our airway area. So we're going to pay close attention to that airway and think about what signs may indicate that that airway is compromised. So think about that. If you said dyspnea and stridor, oxygen desaturation, or even drooling, you would be correct. We're also looking for parathyroid injury. So when that happens, the patient can experience hypocalcemia. So you may have a positive Chostek's sign or Trousseau's sign. Hypercalcemia can lead to tetany or hyperexcitability of nerves and muscles. And then one of our last concerns that we're watching for post-thyroidectomy is a thyroid storm. And when that happens, the patient may experience fever, tachycardia, systolic hypertension, anxiety, tremors, abdominal pain, nausea and vomiting. And this can lead to confusion, psychosis, seizures, coma, and even death. Treatment for thyroid storm, if you want to go to chart 63-5, you will get a list of different treatments. We're looking at airway and ventilation. Again, we're focusing on that airway. We're going to give the patient methimazole or tapazole or PTU to reduce the thyroid hormone. We'll be giving propanolol to help reduce the blood pressure. We'll probably be prescribing some glucocorticoids. And then we want to monitor this patient closely for cardiac dysrhythmias as well. We're also going to be looking at vitals about every 30 minutes. They may choose to use a cooling blanket. They're going to use non-salicylate antipyretics. So what that means is we want to avoid aspirin, and then normal saline for hydration. Our next client that we're going to talk about was diagnosed with hypothyroidism. So consider how you would explain that condition to your client. Hypothyroidism is a condition in which the body lacks sufficient thyroid hormone, and since the main purpose of the thyroid hormone is to run the body's metabolism, it's understandable that people with this condition will have symptoms associated with a slow metabolism. Various causes include inflammation of the thyroid gland, Hashimoto's disease, and this is a condition in which the autoimmune system attacks your thyroid. Our third major cause is medical treatments. And so an example of that would be someone who had surgery, or like I mentioned with hyperthyroidism, we took out the thyroid to treat the hyperthyroidism, and now they develop hypo. Also, surgery for thyroid cancer can contribute to that as well. And there are several other rare causes of hypothyroidism. One of them is when we have a person has a completely normal thyroid gland, but it's not making enough hormone because of a problem in the pituitary gland. So the pituitary gland produces the thyroid stimulating hormone, or TSH, and then the thyroid simply, when that's not happening, it doesn't have that signal to make that hormone, so it doesn't. So sometimes the thyroid's fine, it's the pituitary gland that is the problem. I like to tell a story of my youngest son. He was 16 years old, and he came home from school one day. He'd had the opportunity to donate blood, and he was so excited. He was finally old enough, and so he's, Mom, guess what I got to do today? And so he was sharing with me, and he had a little pamphlet that he had brought that they had given him there, and he set it on the counter, and they had written his vital signs on this pamphlet. And I took a look at it, and his heart rate was about 43. And I said, Jacob, are these your vitals? He's like, yeah, why? And I said, they let you donate with a heart rate of 43? Yeah, is that a problem? And I'm like, you are not a runner. You're a sprinter. You're a football player. You are not a distance runner. You should not have a heart rate in the 40s. So because we nurses like to tell doctors how to take care of our family members, I, of course, called up our family practice doctor and asked when they could get him in. And they said, we can get him in tomorrow. And I said, great. Would you get an EKG on him and check his TSH, his thyroid stimulating hormone? And they did. And a normal TSH is about 0.4 to 4, roughly. There's various reference ranges, but right around that. He was 20. So at 16 years old, no classic signs that you see with people being overweight and that type of thing with him. He was fit, he was young. He was diagnosed with hypothyroidism, and he's had a really rough time getting it regulated. He's 23 now, and I would say an average person takes a dose of Synthroid or levothyroxine of, I don't know, anywhere from 75 to 150. He takes about 225 micrograms a day. It's a very large dose, and he just seems to have a really hard time regulating it over time. So, when we looked back, we noticed that he'd been a little sluggish and lethargic, and he had chosen not to do a winter sport for the first time in his life. And so we thought, well, he's just in the dumps because it's winter, and we all kind of deal with a little bit of that seasonal affective stuff. And so he's just being a slug because he's sitting around and not busy. And, looking back, we realized that he felt like crap all the time because his thyroid wasn't working. And so his pituitary gland was producing large amounts of that TSH to try to get that thyroid to take over, and it did not. And then I had another, if you don't mind me sharing another more recent story, my daughter-in-law she had twins about a little over a year ago, and had her babies, and she lost quite a bit of weight after they were born, and then proceeded to gain all of it back in like 6 to 8 weeks, and wasn't feeling good. She was just feeling absolutely horrible. And so she went to her doctor, and she's like, something's not right. I just don't know what it is. And they checked her thyroid level. Her levels were above 60. I don't remember the exact number, but it was above 60. Her doctor said it was the highest level he'd ever seen in his career. Absolutely shocked. She was just trying to raise these little babies, and she was nursing them both and was just draining her body, and her thyroid was not helping her. So one of the things that I've learned is that when I have a patient who has a low heart rate, that isn't explainable by beta blockers or digoxin or something like that, I'll often dig into the chart a little bit and see if they've ever had a TSH checked. And I actually have had 2 patients when I was working on a cardiac and a med-surg floor where I suggested to the provider to just take a peek at their TSH level, and we found out that, sure enough, they were hypothyroidism, or had hypothyroidism. So we've got a list here of signs and symptoms of hypothyroidism. I'm not going to read all of them to you. You are capable of doing that. But know that each individual patient may have present with different symptoms of this. Not everybody gets all of them. Not everybody gets the same. But what happens, as the thyroid is not producing enough of the hormone, the pituitary gland is going to continue to make additional TSH to try to prompt that thyroid to start doing its job. And that constant bombardment with the high levels of TSH can cause the thyroid to become enlarged and form a goiter. They call that a compensatory goiter. Left untreated, the symptoms will usually progress. Very rarely can complications result in severe life-threatening depression, heart failure, or coma. It's a simple blood test that lets somebody know if they have hypothyroidism. But what's important to know is that, as I mentioned with my son, sometimes it's really hard to get these individuals regulated. Adolescents and perimenopausal women, from what I understand, have the hardest time being able to manage and to get their levels therapeutic. The levothyroxine or Synthroid is one of the medications that they use for treatment. It is a synthetic form of the T4, and so it comes in various doses. There's just a few doses listed here. It goes as low as, I think, even 12.5 and 25. I know I've seen it 88, 112 micrograms, a whole combination. It takes several weeks to reach a therapeutic level. In fact, usually when they start a person on it, they won't even check their levels again for 6 weeks. And then if they make an adjustment, they'll check again in 4 to 6 weeks and continue to make adjustments to get that level. The endocrinologist that my son saw, he told us that he had one of his clients who he went to church with, and this young boy, and he was a young child, younger than my son. He didn't have a very good home environment, and the family wasn't able to, for whatever reason, he didn't go into it, be able to give this boy the medicine as he was supposed to. But he would see this boy in church every Sunday. And so he bought the medication for this boy and would give him his whole week's worth of the medication on Sundays. And he was able to get him at a therapeutic level by treating him that way. Now, that's not the ideal way. Ideally, you take a dose once a day. It's important to take it on an empty stomach with nothing to eat or drink for 30 to 60 minutes after taking it. So often you'll see in the hospital that your night shift staff will administer this at the end of their shift. But I'm starting to see a lot in the hospitals where it's being given at 8 o'clock and 9 o'clock with the other meds that are being administered. And I'm really surprised by that, because I know that calcium blocks the absorption of this medication, which can prevent it from being therapeutic. I have been told there is a genetic component to this as well. So if you have a family member who has it, you may see additional people in the family who deal with this. And this is the end of our recorded lecture for PN2 and for the entire quarter. I thank you for joining in, and I hope that you have found this to be beneficial for your learning, and combining it with the classroom activities has enhanced your ability to be successful with this class. I wish you all the best on your final and as you go into PN3 and prepare for NCLEX.